Hi everyone. Now we are going to discuss about preoperative assessment. Introduction. Preoperative assessment is one of the most important aspects of the conduct of anesthesia. A thorough preoperative assessment is must requirement for all types of anesthesia, whether it is general anesthesia or regional anesthesia. Goals of preoperative assessment: to reduce patient risk and morbidity associated with surgery and coexisting diseases. The second one is promote efficiency and reduce cost. Third, prepare the patient medically and psychologically for anesthesia and surgery. The next one is a screening tool to anticipate and avoid difficulties or problems with anesthetic drugs. The last one is knowledge about contraindications to specific drugs such as succinylcholine, nitrous oxide, or volatile agents should be known before starting anesthesia. The next one is components of preoperative assessment. Review the medical records, obtain a history, and perform a physical examination to the patient and contemplated surgery. Then appropriate laboratory tests and preoperative consultation should be obtained. Finally, anesthesiologist should choose the appropriate anesthetic and care plan. Next, history and physical examination. First, we have to know the history of present illness, current and past medical problems, previous surgical procedures, type of anesthesia, and any anesthesia related complications must be noted. The patient use of tobacco, alcohol, or drugs must be documented. A simple notation of diseases or symptoms such as hypertension, diabetes mellitus, coronary artery diseases, or chest pain. A family history of diseases also be documented. Next, we have to check the airway assessment. For that, first factors causing difficult back and mask ventilations are obese, bearded individual, a person with no teeth, history of snoring, elderly, age above 55 years. The second one is factors causing difficult laryngoscopy and intubation. For that, we have to look externally. Second one is evaluate. Evaluate 3-3-2 rule, which means mouth opening should be more than 5 cm or 3 finger breadth. Hyoid mental distance should be more than 2 finger breadth. Thyroid distance should be more than 2 finger breadth. Next one is thyroid mental distance, the distance between thyroid cartilage and chin. The last one is sternomental distance, a distance of more than 12.5 cm between chin and manubrium sternae is considered. Next one is Mallampati classification. For Mallampati classification, in class 1, facial pillars, soft palate, uvula, posterior pharyngeal wall. In class 2, partial view of facial pillars, soft palate, uvula without tip. In class 3, soft palate and only base of uvula is visible. In class 4, only hard palate is visible. Class 1 and 2 represents easy intubation, but in class 3 and class 4 represents difficult intubation. The next one is Coatmac and Lehenge grading. For that, grade 1 visualization of entire glottis aperture. In grade 2, visualization of just arytenoid cartilages or posterior of glottic aperture. In grade 3, visualization of epiglottis only. In grade 4, visualization of tongue or if tongue and soft palate only. Next, preoperative risk assessment. For preoperative risk assessment, ASA physical status classification, which means ASA 1 represents a normal healthy patient, ASA 2 a patient with mild systemic disease, ASA 3 a patient with mild to moderate systemic disease, ASA 4 a patient with severe systemic disease that is a constant threat to life, ASA 5 a moribund patient who is not expected to survive without the operation, ASA 6 a declared brain dead patient whose organs are being removed for donor purposes.